situation. We're still dealing with a lot of uncertainty, but there's just as much uncertainty on the side of residency programs as there is on your side, and I think that's important to remember. So I told Angie as we were talking about what we were going to talk about to try to make most of this session Q&A so that I can actually answer what's on your minds instead of just talking about what's on my mind. So I'll turn it over to you, Angie.
Okay, so exactly like Dr. O'Connell was saying, we really wanted to maximize the time for you guys to be able to ask questions, burning questions, anything regarding residency application, how to excel on a sub-internship, how to best prepare for your personal statement, how to best prepare for the application season, you know, any questions related to family medicine, primary care, telemedicine, anything in that nature, please feel free to ask that. And I think what I might do is just to throw a couple questions to kind of warm everyone up, and then I'll kind of just have you guys cast questions to Dr. O'Connell. Does that sound like a plan? Okay, so so here are some of the questions I prepared. And for Dr. O'Connell, can you kind of walk us through your day-to-day practice as a family medicine physician before COVID? And then after COVID hit, what are some major changes and adaptations that have happened to local and regional family practice, and as well as AAFP? What are some of the adjustments that you've seen? Thank you.
Absolutely, that's a great question because there are a lot of big differences between how it was 6 or 8 weeks ago and what things look like now. So I'm a family physician, and by nature, that means my practice is quite varied. I do primarily outpatient family medicine, but I do inpatient as well. On the outpatient side, I work with all age groups from birth up through the elderly. That includes procedures and women's health procedures. I don't do prenatal care to OB any longer. I kind of gave that up after I left residency just because there were only so many hours in the day and I had a lot of other interests. I also work in the hospital on a regular basis. I do 1 week at a time, about every 6 or 8 weeks, primarily working with the residents. And I also do some work in our emergency department. I'm involved very actively with teaching. I teach medical students, primarily 3rd and 4th years, both in the clinic and in the hospital. I precept residents on a regular basis, both outpatient and inpatient. And then I run the residency program, so there's a decent amount of time dedicated to making sure that we're accredited and doing great and constantly innovating and evolving. So a lot just in terms of trying to think about how we might pursue medical education differently. And then I have some regional roles with our regional GME office, helping to launch. We've launched, after we launched our residency program 7.5 years ago, we've helped to launch 2 other family medicine residency programs at Kaiser in Northern California, and Sacramento is also about to launch one there and has accreditation approval. So I came up here to start one and helped start 4 altogether. Working on other things regionally around a point of care ultrasound curriculum from a regional standpoint and things like that. So what's going on these days related to practice? We have had an almost complete shift to virtual care and telemedicine within our organization. We were already doing telemedicine and virtual care, which I think really gave us a leg up and an advantage in being able to shift. But as of yesterday, more than 95% of the care provided by our department has become virtual. And so what we do, if somebody is calling for an appointment, we schedule them first for a telephone or video visit and evaluate them. And whenever possible, try to keep them out of the medical center so that we're not potentially exposing them or having them expose other patients and healthcare workers. Obviously, if somebody needs to come in to have an abscess drained or they're having chest pain, we get them either into the clinic or into the emergency department for evaluation. The precepting of our residents has become mostly virtual as well, at least for the family medicine, outpatient family medicine care that they provide. I have a week of inpatient coming up, so I will be joining the group of residents that's currently working in the hospital. We've been doing a lot of preparation around preparing for a surge, which fortunately seems like it's probably not going to happen, but there was a lot of preparation, planning for 400 to 500% of normal hospital census. And so that included training our full-time hospitalists up as like mini intensivists and getting people like myself who already do some hospital medicine ready to do that more full-time. So a lot of prep work. Unfortunately, haven't needed that preparation yet. We've been having a lot of meetings about changing workflows and making sure that we're supporting the residents. We're moving rotations around to make sure that the residents are getting the training that they need so that they can get to graduation, so that they can become board certified. And so that means deploying them, a lot of the outpatient rotations that they were on, rheumatology, orthopedics, et cetera, aren't really happening right now. There's not outpatient care happening outside of our department. And so it means deploying them to the emergency department and to the inpatient service, OB, newborn nursery, electives that make sense, and working both backwards and forwards with their schedule. So we've been given some latitude by the American Board of Family Medicine that will eventually board certify them, and by the ACGME that accredits residency programs. And that we're able to count some of the care in other they're going to be a little bit looser about requirements for residency programs, knowing that you just can't stick with your standard curriculum. So we're looking ahead at their schedules and saying, are there rotations that you would have even 6 or 9 months from now that make sense to put you into, so that you will have done that? And then hopefully once this pandemic has improved, we can go and backfill and get you back into orthopedics or your surgical rotation or whatever you're missing now. So a lot of proactive work and just planning for, whether this is a 3-month thing or probably going to be 6 to 12 months, but we're trying to be proactive about it. You asked about changes kind of in practices in the community. A lot of things are happening. A big time shift to virtual medicine, as I mentioned, for us, but also a lot of smaller practices making that shift and adapting their practices. There are some smaller practices that are closing, and the question will remain whether that's temporary or more permanent. And that's not just family medicine. That's a lot of specialties that just, if the patients can't come in and you can't provide those services, and especially if you're procedurally based and there's not much in the way of elective procedures happening, you have overhead and office staff and cuts are needing to be made. I see a lot of my colleagues, both within Kaiser Permanente and outside, are really looking and figuring out how do you still do some well child care while keeping people safe, because we want these children to continue to get immunized and get the care they need. So trying to figure out what that looks like. For us, it means doing the well care, minimizing the amount of well care, making sure that we're doing the real little babies first, and focusing anybody who needs to come in, making sure the more well people will come in the morning and the less well people in the afternoon. So you're kind of cohorting people. And then bigger picture, I've seen a lot of colleagues becoming very active on social media and even in the traditional media, doing interviews and trying to be real advocates and health policy and try to overcome a lot of the misinformation that you see online and what's being stated by the media. So whether you're looking at LinkedIn or Facebook or Twitter or Instagram, you see a lot of physician voices popping up and people who traditionally have not done that. So it's really nice. And some of that's having a little bit more time on our hands, but I think there's a real urgency around it and concern about how much misinformation is out there. Then I think finally, Angie, you asked about the AAFP and what they're doing. They're trying to provide resources for everybody, and that takes, some of that is educational resources. Some of it's CME, getting everybody up to speed on the whole thing about COVID and testing and treatment. It's evolving very, the research is coming at us. It's not prospective, double-blinded, like good quality research that we all want, and it's hard to keep on top of it. So they're trying to provide resources. They're doing a lot of advocacy with Congress and federal agencies to ensure that FPs are getting prompt communication, updated guidance, the resources they need, urging Congress to make Medicaid a big priority. As people, we're up to 25 million people now in this country that have filed for unemployment. So making sure they have access to Medicaid will be imperative. They're providing guidance on how to prepare one's office and take care of patients, especially offices that are smaller group, individual practice or smaller groups and don't have that experience with virtual medicine. They've joined forces with other medical organizations like the AMA to advocate for direct financial support to frontline physicians. A lot of small businesses are getting bailed out, and making sure that frontline physicians have the financial resources that they need and are getting paid for the work they're doing. There's a lot of advocacy going on around making sure that practices get reimbursed for telehealth and virtual medicine. And now it looks like Medicare is starting to get that message. And then just kind of continue. I think this whole thing is a lesson in terms of the force of primary care and family medicine, and how vital we are just in general. And you see all these family physicians who can easily flex and go work in the hospital or work in the emergency departments in addition to their office practices. And so continuing to advocate for expansion of primary care across the country.
Wow, thank you so much. I think you covered a lot, and I would like to give everyone an opportunity to ask any follow-up questions about what you said, and because you talked about working what is a family physician, workflow, and all the pre and after changes. Anyone has any burning question or follow-up question with what Dr. Elcano just said? Yes, just feel free to speak up.
I see one in the chat box from, I don't want to butcher the name, Spinghar Comac. Maybe if you don't mind just reading your question for everybody, so everybody knows what question I'm answering. And introduce yourself to us. Let us know who you are, where you're from.
Okay, let me get you guys up here. Can you guys see and hear me fine?
Yeah.
Okay, hi everybody. My name is Spinghar Comac. I'm a new fourth-year med student here at UC Davis in Sacramento, California. And it's good to see everybody on board, and I'm happy to get some information from you guys. My question was, in light of the current COVID-19 struggles that everybody's dealing with, do you feel like that eventually some residencies will integrate telemed as part of their curriculum and maybe have that be a standard moving forward, a part of the training?
I believe so. I think this pandemic and the way practices have had to move has done two things. One is it's gotten people more comfortable, or at least realizing they need to do virtual medicine. It's kind of pushing people into the deep end and saying, we're just going to do it because this is what we have to do. And two, I think even for those of us who are already doing it, it has shown us the extent to which you can, how much more care you can actually provide virtually. And you can actually, especially from when you're looking at it organizationally, like for us at Kaiser or at a UC, you can actually, thinking about this from a social justice resources standpoint, you can actually provide care much more efficiently by doing that. And if you're able to care for a few more patients or make it, more efficient, you can actually lower healthcare costs for individuals and society. And then also just thinking about, if you're able to provide somebody virtual care as opposed to bringing them into the office, you've saved them time from, taking time off of work, from finding childcare, from having to deal with traffic, to having to pay for parking, to coming into a medical center where during flu season or URI, people are catching these illnesses. It's not just COVID-19 that they're catching in our waiting rooms. And so you're potentially reducing that. You're reducing the administrative burden on a healthcare system. So I think it's, this is just showing us how many more things things that you don't think you can do virtually, suddenly we're doing it and saying, oh, we can do that just fine. And, you know, the 8 out of these 10 patients didn't need to come in, and we'll see the 2 that we do need to see. From a training standpoint, which I think is kind of the origins of your question, will residency programs start to do this? Some of them already are. You know, they're probably in the minority, and some of that is related to infrastructure. You know, we fortunately already have telemedicine visits and are able to do virtual care through an app on our phone or through our laptop or through our desktop. So it's kind of embedded for my organization. Other organizations need to work on that infrastructure, and we'll get there. The other reason, though, that residencies have not focused on this is for family medicine training, in order for you to graduate from a program and for a program to be accredited, you need to get to a certain number of minimum patients, continuity patients in the family medicine center over the course of 3 years. And that number happens to be 1,650 over 3 years. If you go too high, they actually look at the program and saying, are you working your residents too hard? So most programs try to get into like the 1,1900 range. The ACGME that provides accreditation has not allowed us to count virtual visits. So we do that still. Our residents are trained from day one how to do virtual care. From day one of doing clinical care with us, they are doing virtual care. We have one telemedicine or virtual or video visit built in for every unit of clinic that they have, because our belief is this is the future of medicine. We need to be doing it whether we can count the numbers or not. And you know, so far the ACGME has not allowed it. ACGME is getting a lot of pressure right now from organizations saying, hey, like, we're all doing virtual care. Are you going to count these numbers? And right now they're saying, well, we don't know what we're going to do, but just keep track of everything that you're doing. Everybody's doing things differently right now. And you'll just have to explain to us when this is all over how you trained your residents. I really think that this is going to push them, though, to eventually count it. I and my fellow program directors at Kaiser have written a letter to the ACGME proposing that they start to count this. I've also signed one through UCSF asking the same thing. So we're all, you know, program directors around the country are lobbying them to change their way of thinking. It's, you know, it's 21st century medicine, and they're counting 20th century numbers.
Thank you. Thank you for that.
Thank you for that. And definitely this pandemic was, if anything, accelerated the process of telemedicine, and we still have a lot to unpack, but for the sake of time, we want to try to get through other questions that other students have. So if it's okay with you, so one of our students had a question from Natasha. She actually raised a question that's kind of similar with one of the questions I prepared as well. So for those who are still deciding family medicine, Dr. O'Connell, what really brought you to that conclusion that family medicine is a calling? And was there any, you know, head-to-head top choices when you were in the decision going back to your med school days? And then she's also asking, what are the options for family med inpatient portion, and for those who are more interested in a hospital setting?
Sure. So let me tell you a little bit about my own journey and my own decision-making process and what brought me to it, and then I'll answer that other question as well. So I went into medical school with a pretty open mind. I was initially kind of sure I didn't want to do a surgical subspecialty, but was willing to kind of think about it at least. And as I went through, I initially started settling on pediatrics, and then toyed with the idea of urology and head and neck surgery and a few other specialties, even though I thought I didn't want to do, you know, I got really interested in them for about a week or so. And then I'm somebody who just likes to do a lot of different things, and I think likes variety. And so on these specialty rotations, a week or two into them, I would say, oh, wow, this is kind of repetitive. And I figured if I was feeling that way after a week or two, a 30-year career and that wasn't going to sustain me. So I went through and, could rule some things out. I didn't want to do OBGYN. And I think I just kind of came to the realization with my medicine rotation that I didn't like the idea of doing all this training and gaining all this knowledge in medical school and then giving a lot of it up to focus really intently on one thing. And that's just me. Like, some people love that. And then I got to my family medicine rotation and felt like I had a really, day one, I did a procedure and saw a baby and saw an elderly patient, and it was partially acute care and partially health maintenance. And I just felt like the people there, I had found my tribe. People kind of say that you find your group of people. I felt like I had. I enjoyed the variety of it. I enjoyed the idea and the opportunity to really get to know people longitudinally and over time and take care of multiple generations of patients. I liked the procedural aspect of it. I liked the idea that you could work in a variety of settings, in the clinic, in the emergency department, in a procedural setting, inpatient. If you wanted to, you could do OB. It gives you tremendous opportunity. I liked the kind of public health, community medicine aspect of it as well, and kind of the social justice origins of the specialty. And then it also, I don't know if I originally realized it or if it was something over time, I realized how you can really reinvent yourself within the specialty over time, and you can go more broad, you can go more narrow, you can focus on a particular area, you could, really change lanes entirely and change what you're doing within medicine as far as your career goes. And you could stay with clinical medicine, you could do more administrative stuff. For me, it was teaching and clinical medicine. So all of that kind of led me to it. In terms of the question about inpatient, so we as a residency, the origins of the residency and our core mission is to train our residents in outstanding full spectrum family medicine so that you can go into just about any practice environment and be very successful. And we have already, I've had I just recruited in my 7th class at this residency. And so we've had, I think this is our 4th graduating class coming up. We have residents that are doing, I have one who's a full-time hospitalist, several who are doing part outpatient, part inpatient, a couple who are doing outpatient with OB. Almost all of them do procedures in their practice. And so the answer is yes, you absolutely can do all of this stuff. I would say, unless you're in a kind of rural environment, it's hard to find a position where you're doing all of family medicine, where you're doing inpatient and outpatient and ER and ICU and OB and prenatal and procedures. Like that blows my, there are people who do that and they're great at it and it blows my mind. In cities, it's a little bit harder to find that. And then just depending where you're looking, there will be places where they say, no, we want an outpatient family physician. And other places will say, yeah, well, you're great. Tell us what you want your career to look like and we'll find a way to let you do inpatient and outpatient or outpatient and OB. So it just gets, I always coach our residents that, like, as you get into your 3rd year and start looking at jobs, let's really start talking about how do you position yourself to do that and how do you negotiate for what you want, and realize primary care physicians are in short supply in this country. And you can often ask for what you want, and maybe you'll get 95% of it instead of 100, but try to get the job you want.
Wonderful. Thank you so much for that. And I think a good follow-up question to that, I think as the application season coming up, especially for the M3 students who are thinking about writing their personal statements, thinking about how to package themselves as an applicant, as someone who has read through a lot of the personal statements and going through people's application as a whole, what are some tips and advice do you have for students how to make their personal statement stand out, or, it all sounds cheesy, like why medicine, why family med in particular, but what are some, useful practical tips you have for students for, this is not just for the third year med student, but maybe for M1, M2, just kind of thinking about how to tell your own story?
Sure. Actually, I should say even one more thing before I answer this question so that I don't forget to do it. I'm going to be doing another session on either June 3rd or June 10th, talking all about these topics. I'm going to answer this question absolutely, but another session. And so if any of you want to get we haven't figured out the details, but Angie has my email. If you want to be invited to the other session, send me an email and give me your permission to use your email to add you to the mailing list, and we'll make sure you know when that is. Because we're going to cover, it's going to be all focused around applications and interview season and follow-up and match lists and things like that. So to answer your question, Angie, about personal statements, I will say one, I get this question a lot and actually wrote a blog article that's on my website, so you can dive into that to get my thoughts on a personal statement. So I kind of put this into different categories. When you're thinking about your personal statement, I think you need to realize that that will help you get your foot in the door for getting an interview, but there's a lot of other things that go into your application. Fortunately, a lot of programs are doing holistic review and looking at everything and looking at your board scores and your dean's letter and your personal statement and your letters of recommendation and all of the data that we have. So don't sweat your personal statement too much. I think it's important to realize that it's kind of a bell-shaped curve, and most people's personal statements are really nice, and that you read a few each year that are exceptional and a few each year that are not good. But for the most part, they're somewhere there in the middle and just really, really solid. A couple of things though. One is we are seeing a lot of applicants these days who are applying to more than one specialty. They're being encouraged by their medical schools because of the bottleneck between med school and residency. And one of the ways, I'm going to show you behind the curtain now, one of the ways we try to figure out is if you're really committed to our specialty, because we can't ask you during an interview day. It's not allowed by the NRMP, the National Residency Matching Program. We can't ask you if you're applying to more than one specialty or if you really want to go into so we're just trying to assess it. I encourage everybody to state whoever you're writing your letter of recommendation for, state the specialty in the first paragraph and think about doing it again in the last paragraph. My group looks at that, and if you haven't said the word family medicine in your personal statement, you're probably not getting an interview with us. We get 1,000 applications every year and can interview about 130. So we have to, and we don't want our time wasted by somebody who really wants to be a surgeon and they're using another specialty as a backup, or, so that's the truth. So put it in there. And even if you are applying to more than one, write 2 personal statements and at least be strategic and write internal medicine in one and family medicine in the other, and make sure the personal statements go to the right programs. But programs do this, so that should be in there. I view the personal statements as a way to just really let people get to know you a bit. You shouldn't answer the question, why medicine? Because you did that on your way into medical school. And we get it. You're now a 4th year and applying. I hope you're happy with medicine, right? So you don't need to get into that, but you should talk about what it is that attracts you to that specialty and what makes you unique, or what your strengths are that will add to a residency team. Think about it from my perspective or a faculty member's perspective. What are we looking for in an applicant? We're looking for team players who have great interpersonal and communication skills and a real interest in being in that specialty, and a real interest in medicine, and a real interest for my specialty, in people. And we want to get a sense that, are you going to come in and be a hardworking resident, an outstanding doctor? We're going to be proud of you as a graduate. Are you going to do the right thing for your patients? Are you going to communicate well with your patients and your colleagues and your attendings and nursing staff? that's kind of what we're looking for, right? And so anything that you can say that kind of paints that picture, and whether you give examples about a clinical case that you helped care for, or an example about a difficult situation that you experienced in medical school, there's a lot of different ways to kind of take it, but that's kind of the core messaging. Who are you, and why are we going to be happy to have you as a resident? There's also a real opportunity in there to talk, if you have any blemishes in your application, say you didn't pass a step on the USMLE, or you had to repeat a piece of the coursework, use that in your personal statement, or use the personal statement as a way to talk about that. And you don't have to use the whole personal statement, because then you're blowing an opportunity to talk about other things, but bring it up. And that way, whoever's reviewing your application, they can look at it and say, oh, wow, this person had to repeat a course. I wonder why. And then they read your personal statement and you explain why. And within that, what you really want to do is not assign blame to somebody else. Like, you've got to own it. And whether it was because your grandmother was sick or passed away at that time of the year, or you got ill, or your approach to studying, you realized that you could improve that, like whatever it is, explain it, own it, and talk about how you've grown from that, moved past it, and it won't happen again. Because that's really, again, from our perspective, that's what we want. Somebody who's continually growing. We all make mistakes. We just want to know that you own them and grow from them. And hopefully it won't happen again. And even if it does, like if you have trouble in residency, we want to know, like, are you going to be open to the process of letting us help you and move beyond it? But if we detect blame or something, or not owning it in your personal statement, we're going to go, oh, wow, this is somebody who had some trouble. That's okay. Didn't own it. Maybe not okay. What are they going to do when they're our resident? Are they going to fix it? And that's really what we want to see. This is kind of me personally. I read 1,000 of these every year, and a lot of these personal statements become very formulaic. You said you've read some of them where it becomes like, this is me. This is a patient encounter. This is why I want to do the specialty, or what, and you just start to see this same kind of cadence. So if you can get away from that at all, and like really just tell us about who you are. The personal statement's not going to decide whether you get where you end up on somebody's match list. It's just an opportunity for you to talk about things and who you are, and make sure that it's not a place to regurgitate what's in your resume or your CV. Like, we have that in front of us. So, we don't need to hear about your scholarships or, the research that you did, or unless like you really dove into it and somehow that's influenced who you are, right? Make this is a story about you. And when you read 1,000 of these, I actually like I want the ones that tell me a bit of a story about somebody, right? And then so that I say, well, okay, I'm looking forward to meeting this person when they come for an interview. So think about it in those, like, turn the whole thing around and look at it from, put yourself in the position of a faculty member or a resident who's reading these.
Thank you so much. Those are really good tips. And as I'm personally struggling with just starting the first draft, because it's never perfect to it's not easy to make your personal statement perfect, but it never hurts to start a first draft, and no matter what that looks like. And I think and do you have any advice with like how many drafts we should go through, and what kind of people we should send them for proofread or things like that?
I don't know how many drafts. If you're a gifted writer, that number could be 2, right? And other people struggle, and maybe it's 20, I don't know. But I would say start writing it, or at least write down the ideas about what you want to convey, right? That's the starting point, is what do you want to get the programs to know about you? I would suggest if you're comfortable, having some of your classmates read it, because they're in the same boat and thinking in the same way. And that's a good way to get feedback, especially people that you think will give you honest feedback. You don't want to be saying something in there and have your friends go, that's not you, right? Because then if it's not seeming like your real self, that might come through on your interview day, right? You really just want to be natural and be yourself. And, you know, as a program director, I'm trying to sell the most honest version of the residency that we have, because I don't want anybody coming in and saying, oh, you sold me a bill of goods, or that's not what I thought I was going to get. I want you to see everything, what we're working on, what we think we're great at, what the realities are. And I think that's really, you know, as you don't want to show all your flaws, but you want to be your natural self in that. So definitely, if you can, show it to some classmates. If you have some trusted, you know, professors that you can show it to. And it kind of, I align this idea though with getting letters of recommendation. You want to have people who have experience in that realm reading those, you know, or at least have some people with experience in that realm. Because somebody may love you and think you are an outstanding medical student. If they have no experience writing letters of recommendation, they may actually do you a disservice by writing something that doesn't come across the way it should. And same thing with personal statements. If somebody's not reading a lot of these or doesn't have experience on selection committees, they may not know how to tune it the right way. So I would be thinking in terms of faculty members who serve on selection committees, preferably for residency programs, possibly medical schools, but even there's a difference between selection committees for med schools and residencies too. So, but also think about people in different categories too. Maybe some people outside of medicine, right? Maybe some people with real talent for writing. Definitely somebody who's a good editor and is good grammatically, because you don't want to have any, like no errors, no punctuation, no spelling, no grammatical errors in there. It's just, some programs won't hold it against you, but you just don't want to look sloppy, right? Because then, you know, taking it again from the residency side, you go, oh, that was sloppy. I wonder what else they're sloppy at, right? You just don't want to give anybody any reason to even think that about you. So, but I would say have a lot of people read it. And then be careful about how much of their feedback you take, because you don't want to turn it into a Frankenstein personal statement where you put all these different components in just based on feedback.
Thank you. Just wanted to give everyone else a chance to, any questions regarding to residency applications, sub-internships, interview season, that kind of stuff.
I see some questions coming in if you want to hit those. Or we can have whoever wrote them ask them, so I get to know more people here.
Sounds good.
I asked the question. My name is Estefania. I'm a third year or incoming fourth year at UC Davis. And I guess my question in terms of applying for residency, in terms of like COVID and this whole situation, I was thinking about maybe doing like electives or away rotations to check out different places, but visas is now closed. So I was just wondering, like, our school is telling us that it's probably not going to be likely that we're going to be doing away rotations at this point. So I just wanted to know, since you're a program director, if you have any information about that, if Kaiser will be accepting applications or maybe even considering that in the near future. And then I have like 3 questions. Also, in terms of like ERAS application, we heard that it's possibly going to be pushed back. It's not going to be September, maybe October at this point. So I just wanted to know if you have extra information about that. And also in terms of interviewing, we heard that a lot of programs are thinking about virtual interviews. So I just wanted to sort of like get your thoughts about that, if you think Kaiser is going to be doing that or not. Thank you.
Yeah. So absolutely. And if I forget what any of those 3 questions were, tune me back in. So the first one was around away rotations, electives, sub-Is, and VSAS. So all of this is a moving target. I do want to say that when I talk about what programs are doing, I'm going to paint it in general themes and then tell you what we're doing, because I don't want to speak for other programs either. So part of the challenge here is different schools, medical schools, are doing different things in terms of what they're allowing their students to do. There are some programs, some medical schools that are restarting clinical rotations a little bit, and others like UCSF that I think is on hold until sometime in June. And so it's a heterogeneous population that we're dealing with. We were waiting, our organization had stopped clinical rotations pretty soon after COVID really started to hit. And that was done, I think, out of an abundance of caution, probably a little bit of concern about liability, and mostly about PPE, and worrying about how much we had and not wanting to have multiple people go into each exam room and use up the PPE that we had. And that was really the reason. Now they're realizing that the surge is not probably coming because of the social distancing thing. We probably have enough PPE in our organization. And so just this week, they gave us guidance that we can probably start with sub-I's audition rotations July 1. So we're proceeding with that idea and understanding that because this is a moving target and wanting to be thoughtful about expense for students, that for our sub-I's, we're going to try to favor people who are local or have some reason to be in Northern California for July and August. And because then you're not going to be canceled, if we have to say we can't do it in July, we're sorry, you're not having flights and VRBOs and hotels and things that you potentially are on the hook for from an expense standpoint. We've also picked up the phone. I have a small group of people that help select our sub-I's, and they've actually done a bunch of interviews just talking with people about, what's your situation, like how flexible are you for July and August, to get a sense of this, and really to say to a lot of folks, we're actually really interested in having you come rotate with us. There's so much uncertainty, though. We're probably going to accept fewer people this year. If that happens to be the case, it's not you, it's COVID. And understand that, please still apply. We'd love to have you come rotate with us so we can evaluate you and get you to know, you evaluate us, and we'll get to know one another. We just may not have as much opportunity this year. So we're just trying to be super transparent and let everybody know how much is out of our hands. And then your question about VSAS. So we got a lot of applications already through VSAS. So we were already well down that road. I do understand VSAS closed, I think this week, right? And it's a temporary closure. I don't know how I looked at, there's so many different things happening. It's a couple of weeks that they're closed for. My advice to you is if there's a place you really want to rotate, email them. Because now we're dealing with the same thing you are, where we're like, well, maybe we do want to see more applicants, and VSAS is closed, right? So it's tough on our end too. So if there's a place you really want to rotate, be the proactive one. Maybe you'll be the student who really gets the rotation because you went ahead and did it. And worst case scenario is you're going to get an email back that says, we only accept applications through VSAS, or it's an uncertain time right now. We're trying to figure out what we're doing. But if there's one or two places you really want to rotate, find their coordinator's email address, their program director's email address. That'll get to hopefully the right person. So I'd say go around VSAS a little bit and just ask if there's a way they can review you. The next question you asked was about ERAS. I had not heard that they were pushing back their deadline. It's been September 15th for us for years now. And I haven't seen an email from them or gotten any guidance. So I'm in the dark a little bit on how to answer that particular question for you. It wouldn't surprise me if they did, because it's, with rotations getting pushed back and, it gets harder to get dean's letters. Testing centers are closed, although I just heard May 1, they're going to reopen Prometric so that people can take their boards. But we understand that everything's getting pushed back, and so it wouldn't surprise me. At the same time, ERAS has to work through the realization that we're all doing this in addition to clinical practices. And wintertime, December, January, February is when people take vacations. It's when flu season hits. It's a busy time. And so we try to get our interviews done in October, November, and early December. And I think ERAS, the folks who do all this are probably well aware that it may get tough as you get deeper into December and into January and the holidays and all that. So I don't know what they're going to do. I wish I could give you better guidance on that, but I haven't gotten. They're a different organization than mine. Your last question was about, what was it about?
On like virtual interviewing for residency.
Oh, yes. So we've been having weekly phone calls with our regional GME office just to start to, well, not to start, for all kinds of planning purposes around the surge that we thought was coming, and making sure we keep residents safe, and making sure we have the PPE that we need, and that resident rotations are remaining relatively intact. As part of this meeting just this week, we started to talk about the possibility that we might have to do virtual interviews. And in my mind, that's kind of a double-edged sword. It is great from the standpoint, from kind of like a financial social justice standpoint, where you don't have to fly out to all these different locations and get a rental car and a hotel room. And, we already know you're racking up medical student debt. Some students don't have the same financial situation as others, and there's an inequality there. We get that. We actually 2 years ago did virtual interviews we had 12 spots that we put out there to test, to kind of pilot it. And what we found a couple of things. One is, like, my program that has amazing people. I'm biased, but we have really great residents and faculty, and there's a great chance to bond with people and connect when you're in person. And it's just harder to do that virtually, even when you're doing video. And we wondered how much missed opportunity to just really get to know people and sit down over lunch and just talk, right? And see what you're looking for and what we have to offer, and is that a good fit? We ran into, now Zoom and Teams and Skype and everything seem to be better. 2 years ago, when we were trying to do Skype, we kept running into issues with our firewall, and it was glitchy, and so there were technical challenges. So yeah, it's challenging. We though are starting to proceed as if we might have to do virtual interviews. My preference would be to maybe do I think my preference is in-person interviews and offering some virtually for the, especially considering the social justice and, standpoint, if we can get all the tech stuff worked out. But again, you miss that opportunity to be in person. But if you have to be virtual, we'll do it. I mean, we want to have great residents, and we want all of you to match in your program of choice. And I think I could speak for my fellow program directors out there. We'll figure out a way to make this happen if we have to. I reached out. We're going to start changing I think our website's already really good, but we're going to change it a little bit in anticipation of maybe needing to do more virtual work. Like, we have to show our personality and our people and our culture in different ways if we can't have you on campus. And so I reached out to a bunch of our graduates just this week and said, hey, would you mind here's the list of 8 or 10 questions. Would you answer as many of these as you can on video? If you're willing, like, why'd you choose our program? What did you like about our program? What are you doing? Did our program prepare you for the practice that you want to be in? Just tell people about you and about us and the training. And I think just getting a sense, because you want to know, like, whatever practice you want to be in, you want to know that a residency program is going to prepare you for it, and you want to know that you're going to fit culturally, and you want to know, like, what are these people all about and who are they? Video is one way to do that. And so I'm trying to put more content in there just to try to also understanding, like, these sub-Is in July and August might not happen. And so that's fewer people you get to interact with. So we're going to proceed as if we might need to do that, and hope that we can still do in-person interviews. Was
Thank
it-
you so much.
No problem.
And then just trying to guess through some of the questions people posted in the chat, sort of a related question to the sub-I. Someone asked if we already interviewed for sub-I. When can we expect to hear back about the results? And I think
Oh, with us?
Mhm.
Really soon.
Or,
I sat down on, these days all blend together. I think it was yesterday morning with our committee that looks at all of these. We have a diversity and social justice committee that is involved with our entire selection for the residency, but we start even prior to sub-I application season. But I sat down with the committee that looks at sub-Is along with the diversity and social justice group, looking at all of these, and I think they're about ready to send out offers. I think they were pausing a little bit because of this July and August piece and just being really thoughtful. So really soon, I wish I had a date that I could tell you. This week or next, I think is the answer. If you guys don't mind me being rude and texting one of them, I'll ask the head of our committee while we're here, and I'll give you a firmer answer.
Great. And well, Dr. O'Connell text his colleagues, and just want to make sure to that we cover all the questions here. And I think there are a couple more questions about sub-Is. Nico?
The other thing I always like to say, I'm sorry, about sub-Is is no matter where it is that you're applying, if you realize that programs have limited numbers of sub-Is, and if you don't get a sub-I, don't let that hold you back at all. You can still find other ways, if there's a program you're really interested in, there's other ways to get involved through research. Once things get rolling a little bit, again, volunteer opportunities, just making connections, email, just trying to develop a little bit of a relationship. We match people every year that we weren't able to offer them a sub-I, and then they come through and blow us away during the interview process. So there's seriously no judgment about you as a person. We're just, all the programs are just, we get about 10 applications for every spot that we have. So, it's just the reality, but don't let that hold you back, and don't let it does not have any, it's not a judgment on you at all. Okay, I'm asking when we're going to be sending out acceptances. All right.
And I think someone was asking if for some reason that we aren't able to complete a sub-I before the residency deadline application in September, October, would that be okay? And on the contrary, if we do too many sub-Is, will we look too eager, or would that look bad upon us? I think that was one of the questions someone was asking.
If you don't mind, whoever was asking the question, could you ask them to ask it so I can clarify? I want to make sure I clarify what question they're actually asking.
Okay, Nico? You here, Nico? Dichi? Sorry, I'm not. She here? Okay.
If not, okay, I'll try to answer it. So the question is, the deadline is October. What is that the deadline for? Applying for a sub-I?
Mm-hmm.
Yeah, I would say no, you should be applying for sub-Is way before. Like, this is the time to be applying. The sub-Is run, usually from June, July through, depending on the program, December, January, sometimes February. So don't wait till October, because those spots are going to be gone. And really, if you're applying in October, the match lists are due in mid-February. So think about it in those terms. Like, the scheduling cycle, now is the time to be getting on it. I know that VSAS is close. I'm not trying to freak anybody out. But when it opens, get back on it now, so that you have, same thing. If September 15th is when ERAS opens, have your application in on September 15th, because that's when programs start looking and start making offers. And if you're late at all, you'll have fewer potential slots to be scheduled in for interviews.
I think I can clarify that question a little bit.
Sure.
So I wasn't the one who asked the question, but I think we're all kind of advised to do our sub-Is before October. I think that's where that person was getting at,
Okay.
because the interview season starts in October. So if we don't, because of coronavirus, if we don't get a sub-I position before October, is it okay to wait until after interview? And what is the pros and cons of waiting until after the interview?
Yeah, I mean, we do sub-Is at least until December and usually even into January. And that's so that we can see more people and have more rotators. So I would push back against that advice about October. I suppose it's nice to have it done by then, but I also, we all the time we'll have somebody rotating with us, and one of the days in the middle of their rotation, they're interviewing, and it makes for an interesting switch in roles, but they're also fresh on our mind too, right? They're right there with you all month, and then they're interviewing. I would say that there might actually be some subtle advantage to that. And then this year, everything's out, all of the normal kind of rules are out of the book. I think a lot of people will be doing sub-Is well into the end of the year. I'm getting a text back. I think I don't have the answer for you yet.
And Dr. O'Connor, I know that you have a meeting at 6 o'clock, and I just want to be aware of your time here. And what would be a good cutoff time for you before we?
If you guys are finding this worthwhile, I'll keep going until 5 minutes to 6, and then just bounce from one to the next. I'm chairing a scholarship committee, so we're giving away money for medical students at 6 o'clock. So that's a worthwhile reason to go. I have another 15 minutes.
Okay, great. I think is Veronica here? You have 2 questions?
Hi, yeah, I'm right here. Hi, Dr. O'Connell. It's nice to meet you. So I'm actually wondering about students that aren't in California or on the West Coast. So I'm from Massachusetts. And I was really looking forward to doing sub-I in California, and applied to one at Kaiser.
Kaiser, I hope.
Your Kaiser.
Okay, good. Yeah.
I wanted to know, what you think about students like me who probably aren't going to be able to, demonstrate their interest in, coming to the West Coast, coming to your program through an away rotation.
The question is, how do you demonstrate interest?
No, well, I mean, sure. I'm curious, if you think that it's going to be harder for people from, maybe the East Coast, or I guess anywhere outside of California, to get interviews or show their interest in your program.
I don't think so. Like for one, like I said, we really know that this is a very different year, and that the opportunities aren't going to be the same. I wouldn't want you, if we were going to start interviews this week, I wouldn't want you getting on a plane to come or rotations, putting your safety at risk to travel. So we get it that it's a different year. Somebody maybe have their mic on and is coughing or something. Are you guys hearing that, or is that just me?
I think it's my mic. My roommates are playing cards.
Oh, okay. No worries. So we get it that it's a totally different year. We also know that in California, there are a lot of people who want to come to California for one reason or another. Sometimes it's the weather. There are a lot of Californians who go out of state for medical school and then want to come back. Like, we get it. And I wouldn't let this pandemic worry you. Programs want to have really outstanding residents. They want to have diversity. They want to, we're just as eager to get the right people into our programs as you are to get into them. And I think that's important to remember, that this really is a two-way street. So there are other ways to interact. You know, any interaction you can have with residents or faculty is potentially helpful. And I think keeping that in mind, and you know, we all have to figure our way through this, as we, like I mentioned, putting videos out and trying to figure out, we're going to be doing some more virtual stuff like this, try to develop relationships with the expectation that things are probably not going to be normal into early summer. And the answer to your questions about sub-Is for us, it sounds like they're going out tomorrow as conditional acceptances, with the understanding that we don't know what things are going to look like July 1.
Dr. O'Connell, I just had one other question about letters of recommendation.
Yeah.
My school isn't gonna start up clinical rotations and you know, sub-Is for 4th years until probably July, and you know, with that, there's really limited time to get enough rotations to get letters of recommendation. So I wanted to know, you know, what your program thinks about that, if it's, how many is an okay amount to have.
Yeah, I hadn't actually thought about it, so I'm going to tell you I don't know, but realize that we know that things are completely crazy right now. And you know, if you're in New York City, your attendings are probably way more busy doing clinical care than they are their ability to write letters for you. We get it. We get it that you're not gonna, you know, it's gonna be harder to do a family medicine or whatever specialty you're going into. Doing a sub-I and getting a letter of recommendation from that sub-I for whatever specialty you want to go into. This is a different year. This is a different world right now. We all get it. I wouldn't be surprised if we have people who have fewer than the 3 letters of recommendation that we want, and that we shrug our shoulders and go, oh, well, like this, the world's crazy right now. We get it. Not a big deal. At the same time, I would think about, on your 3rd year rotations, are there people that you really worked with on the clinical side who thought highly of your work, and should you be thinking about them and contacting them early, like while you're still fresh on their minds, and at least talking, like you don't even have to ask them for it yet, but you can just lay ask to have a meeting with them, talk to them about it, say, you know, and I think it's absolutely fine to be open and say, I'm applying to, you know, OBGYN, whatever everybody's on this call is applying to. I'm applying to this specialty. Normally I would be doing a sub-I and trying to get some letters in that specialty. I really appreciated when we worked together. I think I performed well. In the event that I can't get a letter from a family medicine attending, would you, as my rheumatologist or my rheumatology attending, be willing to write me a letter, a strong letter, and see what the answer is? And that way they also have you're not using them as second fiddle. You're just using, you know, it's a different time. And if somebody said somebody's going into surgery and says that to me, I would say, sure, yeah, I'll write you a letter. Absolutely. Why not? Or let me know when you need it. And if you end up getting your surgery rotations, go get your letters from the surgeons, because that's going to be better for your application. But we all get it. Most of us get it. I don't want to speak for everybody.
Thanks so much.
Yep.
And whoever would like to ask questions, just keep going. I think we'll just try to guess for maybe 1 or 2 more before Dr. O'Connell has to go. See.
There's a question there about OBGYN, about pushing back the application cycle. And if Abigail wants to ask that question, that's great.
Sorry, Dr. O'Connell. Hi, it was me. Nice to talk to you again. So it was just a statement. I know that there have been questions regarding pushing back application deadlines, and our university sent out an official statement from APOG and CREOG, the OBGYN like officiating organization nationally, that they're pushing back their deadline to October. And so they just informed us that most likely a lot of other specialties will follow. So I was just kind of letting other people know about that. But I do have a question.
Yeah.
But I know Michael Aris.
I have a comment about that too, if you don't mind. So
Oh, no problem.
other specialties may push their dates back. OBGYN has been much more unified in their approach than any other specialty out there. You know, ER, emergency medicine, has a standardized letter of recommendation that they use, and so they've become unified in that front.
Yeah.
OBGYN this year agreed to have send out their acceptance, their interview offers on the same day, I think even at the same time, so that it wouldn't be this rolling thing, and people would really be applicants would have the opportunity to say yes to the places they really want to go instead of taking the ones that they weren't as interested in. It's about letting people focus on the ones that they want. And so I would say they're probably an outlier in terms of being that unified and pushing it back too. And so I don't know what all the other specialties are going to do. So they're a little unique is my point.
I do have a separate question, but I see that Michael Arias asked before me. So because of time, I'll let them go.
That's okay. You can ask. No, go ahead. You didn't get your question asked and you're first in the queue. You got the mic, so go for it.
So my question is kind of more back on the base of COVID and what's been going on with the changes and how there might be foreseeing changes with how interactions with patients are going to be expected in the future. But because of Vallejo's diverse population and obviously the different languages that a lot of our patients speak wherever we are in the country, most of the times we either have the computer or in-person interpreter to help with communication between patients. How has that changed so far as you've transitioned to more virtual teleconference, telemedicine settings? And moving forward, like what kind of changes or implementations do you foresee to make sure that patients are still able to get the same kind of standard of treatment, given that we don't all speak English?
Yes, so I personally haven't seen that change yet with the shift. And I think it's probably because we were already doing virtual medicine and had gotten used to it. So we have access to a language line. And when somebody's, so when we call somebody on their profile, it tells us their preferred language. And so instead of calling them direct, we call the language line. The language line calls the patient, asks how you would like to be introduced and start off the call. And then you have the interpreter services. The place that I haven't really experienced it, like video, we were not doing nearly as robustly as we were telemedicine. And now there's actually been a big push towards doing more of that. And when we're in the office seeing a patient in person, we can do the interpretation either there's a phone in each exam room, and so we can use the language line that way. And there's an iPad on rollers, and there's video interpretation services that you can just roll right into the room. And so if you're doing a video visit, I'd have to look into it to see how, I don't think the iPad piece would work. I assume we would just call the language line and do that, but my experience on that is limited. But yeah, the organizational imperative is that you meet the patient in their preferred language. It's better care, right? I think we all know that.
Thank you.
Sure.
Michael's up.
Michael Arias, I think you're up.
Yes, sir. This is Michael Arias. I'm a third-year medical student at the Burrell College of Osteopathic Medicine at New Mexico State University. My question is, from the video on your website, you talked about how there's about up to 40% pediatrics planned in the patient panels for your residents, whereas some other family medicine programs struggle to get even 20%. I'm wondering if that's about more or less half and half inpatient versus outpatient, and if the COVID situation changes any aspect of that distribution.
So that number that I'm quoting, the expectation for family medicine from the ACGME for accreditation is that residency programs get to 10% in the resident panels. Ours is 30 to 40%. We just committed from the launch of the program that we were going to be really competent at pediatrics. My experience has been over the years has been a lot of graduates come out of family medicine programs a lot more comfortable with adult primary care or adult care than they are with children. And I wanted to make sure that wouldn't be the case with our program. And so we had a lot of conversations with our pediatric colleagues from the beginning, and they've been very helpful in getting those numbers to where we need them to be. So each of our residents in their panels has 30 to 40%. How has it switched? COVID actually, this pandemic has actually temporarily only, but it has affected it. And the way that it has affected is for the in-person care that we're doing, decision was made in our medical center that our pediatricians were going to see the kids in office and not in the family medicine department, at least initially. That is now changing, but for the first month or 5 weeks of this, and that was to cohort people. Same way we're trying to keep people away and try to see that healthy people in the morning and the sicker people in the afternoon. It was to keep the kids away from the adult population when normally they'd be much more mixed. And it's as much about not having kids be the vectors to the adults as anything. And really they were trying to keep the kids out of the medical center entirely, but it was seeing up to 4 months for well child checks and things to make sure that they're getting their initial vaccines. Now we're starting to expand beyond 4 months, do some well child care, and they're moving back into our department. So it was a temporary strategic thing to try to flatten the curve.
Thank you so much.
Sure. And then on the ER, inpatient, all that, like that's kind of all comers, but we have a lot of peds. I'm not here to promote my residency program, but a lot of peds built in a lot of other venues as well.
Okay. I think Kira has a real quick question about with also regarding to COVID, and given how COVID has expanded the role. Is Kira still here?
Hi, yeah, I'm here.
Yeah.
My question was basically how, Dr. O'Connell, you were talking about how the role of family physicians has changed with COVID, and they're now stepping into the ER, admitting patients on the wards. And so I was wondering, will residency programs now shift to full spectrum family medicine or training their
Well, yeah, residency training in family medicine is already full spectrum, or it's supposed to be. Different programs have different areas of strength, and different programs have different realities. I mean, there are programs that have trouble getting peds into the practice, or they have trouble getting like a strong ICU experience or whatever it is. Part of the reason why I agreed to start this program was I saw the substrate for how strong we could be across the board, and came in, and that was the original plan. We were going to be full scope, committed to being strong in every piece. It would have been easier for us to say, oh, well, no, we don't need to be strong in OB because maybe there's a move in family medicine away from OB. But I didn't want to do that. And I also think then you miss out on really good applicants who are interested in the OB part of family medicine. And so I don't think that's going to change the approach to family medicine training. It's just, you really have to do your homework as you look at family medicine programs and do your interviews and figure out what they're good at and where they're not as strong. And also just philosophically, what are they committed to? We're starting to see some programs that are a little bit more outpatient focused. And that's, if you know you're going to do outpatient only, that might be the right program for you. My counter to that is, I think you can be a better outpatient doctor by committing to being a good inpatient doctor, even if it's only during your training, because those same patients that show up in rapid AFib and go into the hospital, they show up in your office, and you need to be able to recognize and manage some of that and manage them when they come back out of the hospital. So I'm committed to training our residents full scope, because I think it makes them better doctors regardless of what they decide to do after. My philosophy is narrow your practice after residency. Don't have it narrowed for you because of your residency.
Thank you. And with that, I think we actually covered everyone's question in the chat.
Good.
That's awesome. And then before we end this, I just wanted to, because we're kind of tight on time, I was wondering, Dr. O'Connell, could you give us a little more information about that talk we spoke about that's going to happen in early June? And
yes.
For those of us who are interested.
Absolutely. I'll say two things. One is if this is valuable to all of you and you want to give up another afternoon hour in the afternoon and evening, I'll do this again and cover more questions, more topics. That's absolutely fine with me. There's going to be another one. It's going to be either June 3rd or June 10th. And it's going to be all about some of the questions that you guys all asked, but around how to perform really well on rotations and get a great letter of recommendation, how to prepare yourself for interviews, do's and don'ts on the interview day and follow up, and how to make yourself more attractive as a match applicant and things like that. Focus really towards third and fourth year students, although I think there's plenty of things that a first or second year student could tuck away. I was trying to think of how I can let you know about that. I think the easiest way is, if you're interested in it, just email me or email Angie and as long as you're willing to let us use your email to let you know about it. We'll be happy to let you know once the date and time is all set. The other thing I wanted to add is I'm in the process, I'm getting a lot of emails from students kind of wanting to get involved, wanting to be engaged, just wanting to do things I think there's pent up energy and a real desire to be involved in this process. And so I've been working with my own projects and also different cohorts of students, and I'm putting together an email that'll outline opportunities in case you want to get plugged in terms of doing summaries of COVID research or getting involved in some of the stuff that I'm doing. And so if you're interested in that, shoot me an email. I'll put you on the distribution list for that. It'll probably go out in a week or two. I just want to make sure it's all squared away. So feel free to reach out.
Yeah, and if you would like, I could share a Google Doc in this chat group and then have everyone enter your email address. And that way we get a compiled email list with that.
That's great too. Whatever you want to do, as long I just don't want anybody to feel like they're being spammed. So I want to be thoughtful about any emails I send out. So if you give us your email, you're going to hear about this event in June and also some opportunities to get engaged and to learn.
Okay. And also one last thing, I forgot to ask beforehand, before the meeting started, that we're recording the session. So if anyone would like to have your face blurred out, please email me. I'll put my email address in there. But sorry, I forgot to mention this. So that for those students who can't make it but still would like to have this opportunity, I just want to give you guys a heads up.
Fortunately, I don't think we did anything too controversial that anybody needs to be worried about, but it's actually a good point. If any of you are, if this is being recorded and any of you are replying to multiple specialties and ask, feel free to get yourself blurred. I wouldn't worry about it though. No, there's no program directors who are going to go and look for that kind of thing. And if they are, they're nuts and you should avoid them.
And let's just give Dr. O'Connell a round of applause for his time and energy for spending this afternoon with us. And we really appreciate you entertaining all our questions. And we hope to do this again with you, hopefully at our convenience. And anyone has any questions, feel free to reach out. And I put out a Google Doc in this chat. So if anyone would be interested in putting your emails here, and I'll send this Google Doc to Dr. O'Connell.
Yeah, the last thing I want to say before I bounce over to this other meeting, we really understand how stressful and anxiety producing this is, being in your shoes, having your rotations put on hold, having the whole application process be uncertain. We understand, we want to do whatever we can to help smooth the process, which is part of why I want to be on this call. If there's anything that we can help you with along the process to help make it easier, let us know. But if I'm happy to get back on another one of these and talk more through the process, because I think the more you know and the more you've thought about it, the less anxiety there is about the entire process, and you'll just go in that much more knowledgeable. So everybody have a great evening. Thanks for joining us. Stay safe.
Thank you. You too.
All right.
Thank you so much. Bye,
Bye-bye.
everyone. Stay safe.